I'm Dr. Allan Perel, and this is Conversations in Medicine. Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine, a program bringing you cutting-edge topics in the field of medicine for Staten Island and the entire tri-state community. Today's topic is cardiology. Cardiology is the heart, the science and medicine of the heart. Heart disease is the movie killer in the United States. It leads to a tremendous amount of physical and even mental and emotional disability in this world. We have the privilege, I have the privilege of having three wonderful experts in the field of cardiology who will enlighten us tonight about what's going on in the field and what's new. First is Dr. Richard Grodman, who's the Chief of Cardiology at Richmond University Medical Center. Welcome.
Hi, Allan.
Dr. Srini Duvari is the Director of Interventional Cardiology at Richmond University Medical Center. And Dr. Tony Caracta, who's a good friend, as everyone else is, who's a cardiologist in practice on Staten Island for over 35 years. It seems like yesterday, right? Yes. And really helped bring about many of the original things, many original treatments and many original cardiac processes to Staten Island. I want to say welcome everyone. For Dr. Caracta, Dr. Grodman, and Dr. Duvari. So just to get started, what's a cardiologist?
Right. Sounds like an obvious question, but a cardiologist is someone who, by virtue of their training and experience, takes care of the cardiovascular system, which is the heart and the major blood vessels of the body.
So tell me, I know you all work with residents and fellows, we call them. How does someone get trained to be a cardiologist?
Okay, I'll answer that simply because that's my job. I train cardiologists for the last 35 plus years. And it's a long haul for anyone who's interested. So it's 4 years of college, 4 years of medical school, 3 years of residency training in internal medicine. So all are qualified internists, 3 years of training in general cardiology, and then the option for 1 or 2 more years in specific fields of cardiology.
So it's a long haul. Yeah. And it's something that I'm sure you all love to do, because I see you all at the hospital so often and all over. And really, your love for it really does come through your patients and care. So Dr. Duvari, tell me about the physical exam. Some people say that with technology, we really don't need to even touch a patient anymore. What do you think about that?
Well, until we get to complete artificial intelligence, so we still believe in the art of healing by touch. So it's important to, for now, let's take the history and listen to the patient, listen to the heart, the lungs, feel the pulses, and just the act of touching the person has some healing, and at least you connect with the person. So I think physical exam is a very integral part of medicine to date.
Equally important, what Dr. Duvari said, is the history. That's very important, and I think all these tests that we have now, that we have developed and perfected is good, but a good history and a physical examination is important. For example, if you have a patient with, say, symptom of angina, okay, you have to get a good history of the patient. So if the history shows that, oh, when I walk up the stairs, I'm having the chest discomfort for 1 to 5 minutes, but when I stop, you know, it goes away. Okay, and it's predictable. I do the same time and same thing. And you know what? The probability of my doing a test will be positive for that patient because of a good history. In addition, a patient comes to you and says, hey, I have diabetes. I don't have chest pain. But when I walk from my car to the house, I get short of breath. I'm breathless. Okay? And that's what we tell our fellows, the residents, that's a so-called anginal equivalent in patients who have atypical presentation of their chest pain. So if one gets that history, and then if you're lucky during the episode, you do a physical examination, like you said, People are not listening to the heart sounds anymore, but if you hear a gallop, of an S4 gallop, they call it, and then you can see that after the episode of the pain is gone and is gone away, I can bet you your bottom dollar that patient has structural heart disease. And then you can order properly the test that you will do.
Because you do, and we all, whether in my field of neurology and what you guys do as cardiologists, we almost know what the results of the test will be before the patient goes for the test. You mentioned diabetics, and they have very different symptoms sometimes of heart disease. They don't always have the pain and different things like that. Maybe I'll go back to Dr. Grobman. Tell me about women with regard to heart disease.
Well,
we're hearing so much about
right.
women being different, underdiagnosed with coronary artery disease, not recognizing it, and we see it in the beginning of February of every year, everyone's wearing red for the Heart Association. Tell me about do you look at a woman differently than a man with heart disease and when they come to your office?
People do, but you should not. Women are just like men. In fact, women have a very high death rate from cardiovascular disease, and people like to say their aging process is 10 years behind that of a man, but by the time they get into the 60s and 70s, the incidence of coronary artery disease, heart disease, is just the same. So we definitely should not poo-poo women's symptoms. Certainly they have every right to the full diagnostic workup that men have.
That's important to say. So now we're going to go over some of the tests. And some of the tests that we go over are things that we've all heard about, but I don't think everyone knows what they are. And I have a wonderful audience, very bright audience, people who really are involved in medicine and their own care. So if I ask you, and Tony, I see you a lot at the hospital, and I see your name on the EKG or
Yes.
ECG.
Yes.
Tell us what that stands for, and what is that really a test of?
The EKG is called electrocardiogram. It's a very simple test, and it's probably one of the standards that we do when you evaluate a patient, because it gives you a lot of things. If you have a normal EKG, that's no big problem. But if you have an abnormal EKG, it tells you a lot, whether there has been previous damage or structural damage to the heart, or there's an ongoing damage to the heart, or more important, is the heart irregular? There's an arrhythmia? And where is it coming from? Is it coming from the chamber of the top chamber called the atrium or the ventricle? So it's important that we do that. And not only that, it's important to look at the cardiogram serially so you can compare. You have to look at what was done before and you can compare any changes. Because there's some abnormal cardiograms that should raise a red flag and notify the people who ordered it to make sure that they're aware and they should be followed up.
And that's important.
That's
So with
important.
electronic medical records, we're able to, in hospitals and even from your office, be able to see the old EKG and see what's happening with the new one. So is that more of a screening type of test in most patients?
Basically, it's a screening test, and it depends on also what the reason the cardiogram was done for. The patient came in with a specific complaint that could be attributable to the heart or to an abnormal rhythm or anything else. Then it's important you have that piece of paper that you can diagnose right away.
Let's talk about echocardiograms. And we have a model out here, so maybe that could help a little bit. Tell us what an echocardiogram. Many of us have gotten recommended by their internist, their cardiologist, that we get an echocardiogram. What does it mean, and what are we looking
I believe
at?
an echocardiogram is one of the most amazing tests and bang for the buck that there is out there, because it can look at the structure of the heart, all the chambers, all the valves. It's non-invasive. It takes 30 minutes. And people have echo machines even in the office, specialized ones in the hospital. So it can determine an awful lot about the heart, not everything. It can't tell whether somebody has active coronary artery disease. There are other tests for that. But the function of the heart, heart failure, heart valve, disabilities, and so on and so forth. Great test.
Maybe we could look at the heart a little bit. We have this wonderful model you brought in. And tell us a little bit, with an echocardiogram is an ultrasound test. So we think about it, we know when someone is pregnant, they're able to look at the baby and see, the sex of the baby, whether the baby's maturing properly. And we know it's a benign test. There's no x-rays or radiation involved with this. But what can an ultrasound or an echocardiogram actually show us in the heart?
Well, for example, If you look at the pumping chamber of the heart over here, these are called the ventricles. You can actually see their size, their function, wall thickness, things like that. If you were to look inside the heart at valves of the heart and things like that, this happens to be what's called the mitral valve, you can tell whether it works, whether it's tight, whether it's leaky. There are 4 valves in the heart. All of them can be very easily seen. If you need a better look at the heart, you can do what's called a transesophageal echo.
Which means what?
Well, it's a sonogram done from an instrument that's placed in the esophagus. So the esophagus is right next to the heart, and you get wonderful pictures. You can also do an echocardiogram during stress, a stress echo, to see how the heart behaves when it's subject to stress. So all of these are different modalities for echocardiography.
And as a neurologist, I deal a lot with stroke. And we always use the term cardioembolic event. So if someone has something abnormal in the heart and blood sits there, it forms a clot.
Correct.
And with the heart pumping, those clots can go further downstream into the carotid artery, and it could actually cause strokes. And we're always concerned about that. And everybody who has a stroke, one of the workup parts of it is getting an echocardiogram and making sure the heart's okay.
Allan, about 25% of your strokes come from the heart because of a condition called atrial fibrillation. So you have to be aware of that.
So as you said, the irregular heartbeat could also cause that, because if blood is not flowing, because if the part of the valve, maybe we could show the atrium is the top of the valve, is that if it's not moving
right
and
through here.
blood will sit there, it'll clot, just like it does in a test tube. It'll then break off and
Yeah,
go into the
mostly they start in the left atrial appendage, and that's where they start. And then they start to spread, and one of that can just lift up, goes to your brain or to your peripheral circulation.
Right, and that's dangerous because we need our arteries to be open in order for things to flow, for blood to flow through. So Dr. DeVore, I know you do a lot of work with interventional cardiology. So tell us about a catheterization. What are we looking for? I know you brought some instruments here to give us a little idea. If someone has an EKG that's abnormal or an echocardiogram, sometimes we refer people to actually get a catheterization. How is it done? Why is it done?
Yes, as we were talking earlier, it's by the time they come to me, people have already seen their primary care doctor or the nurse practitioner or the physician extenders, and they've had an EKG, and they've gone to maybe a diagnostic cardiologist who's done all the workup, did a stress test, whether a stress echo or a nuclear stress test, and they suspect that there's a blockage in one or more of the major coronary arteries.
I'm going to stop here. So when you talked about all those stress tests, Dr. Grobman mentioned different stress tests, what are they looking for in a stress test? Because so many people go for them routinely over the age of 50. Sure. And what are the guidelines? When should someone go for a stress test?
Well, there are a few of the things that you look for is if people have risk factors for blockages. What are the risk factors? As we get older, that's a risk. None of us are getting younger. And then there are other things such as high blood pressure, diabetes, high cholesterol, anybody who's had family history of heart disease, anybody who is a smoker, family history particularly in a young age. Let's say my father had heart attack in the 45, then I better start worrying from the time I'm maybe 35 and fix my risk factors that I can, such as not smoking, exercising, watching my weight and things like that. So these are the people with the risk factors that undergo the stress test.
And what is a stress test? You're stressing the heart, you're doing exercise. I remember the old way we think about it, you go on a treadmill and someone will do either an echocardiogram or other test on you, whether it's a nuclear stress test, to see if the heart's getting enough blood supply and oxygen.
Correct. So first you want to see what is their exercise capacity. And more importantly, we're looking to see how is the blood flow in the different segments of the heart. This can be looked at either by imaging, what we call nuclear imaging, where it actually shows how is the blood flow at rest to the different segments of the heart. And we're talking about the main pumping chamber or the left ventricle, which is here, the front, the bottom, the back, or the septum, which is the wall that separates the right and left ventricles. That's imaging with the nuclear test. When we do the stress echo, as Dr. Grodman does it, then we look at how is the heart muscle thickening. Normal people, the heart muscle gets faster and gets even thicker than at rest with exercise. And if there's decreased blood flow and oxygen, that part of the heart muscle does not thicken. It actually gets weaker with exercise. So depending on which part of the heart is not working well, then we suspect which artery may be involved.
And then with the catheterization, you could tell?
Yes, so we have three major arteries. On the left side begins as one main artery that divides into this front artery called the left anterior descending, and this other one that goes to the back, that's called the circumflex. And then the third major artery comes on the right side, it's called the right coronary, which supplies mostly the bottom of the pumping chamber. So the catheterization is a way where we put a tube either from the groin in the artery or from the wrist. I brought one of the catheters.
So that's a real catheter. That's the size of
This
what's
is the
put
catheter
in.
that goes up. Yeah. So these are about 2 millimeters in diameter. Some of them are smaller, 1.7 millimeters. So you thread them either from the wrist or from the groin up to the heart, and we engage or put the tip of the catheter into the main artery, and then another one into the right coronary, inject contrast or dye, we call it for simplicity,
Right.
and which helps us to visualize it under x-rays and see if there's any blockage.
And that's
Or
important.
blockages, yes.
And if there is blockages, there are different treatments for them, including stenting, angioplasty, or sometimes surgery.
Yes.
So we'll go into that. I mean, it's hard to talk about all these topics tonight, but at least we could talk about some of them. What I want to do is take some of the fear and some of the concern out. And I'll ask Tony, so many of our patients have something called mitral valve prolapse, particularly young women. An internist or cardiologist listens to their heart and they hear something that's not right. And they do this echocardiogram. And so many of my patients come to me and say, I've got mitral valve prolapse. And I'm not sure if I'm supposed to be anxious about it. Should I say don't worry about it? What do you do and how do you define that?
I don't want to be facetious, but I would say so. Because 30 years ago, as you remember, when the echocardiogram was coming out, any young female that comes to the office with palpitation or a skip beat and gets an echocardiogram is labeled a mitral valve prolapse. In addition, even if you didn't hear any mitral click, because it could be transient. It depends on the volume of the left ventricle. So what happened is that everybody comes to my office and says, I have mitral valve prolapse. And at that time, everything was very important. Dr. Perel was the one who looked at and shows us in how the mitral valve is flipping up and down, and it's giving rise to sometimes ischemia or what we call extra beats like PVCs, or ventricular premature beats or contraction. And so they will then Dr. Grodman will do the echo, and there will be no prolapse, right? But there are some patients that do have prolapse. And it is important because you have to follow those patients later on, because later on in life, they develop some mitral valve insufficiency. So you don't poo-poo it. But you don't have to rush and give them antibiotic prophylaxis
Meaning
anymore.
if you go to the dentist, you don't need antibiotics.
Not anymore, unless you can, like Dr. Grodman will show us that this patient has a moderate to severe mitral regurgitation with the prolapse, or if the patient has a very specific condition called Marfan syndrome. Okay, we have some patients with Marfan syndrome where they have a myxomatous mitral valve and will prolapse and give rise to that. Now, those are the patients I'll be very careful and make sure they have antibiotic prophylaxis. But for patients who have diagnosed with mitral valve click prolapse, you don't need any more antibiotics.
Usually we don't have to worry too much about it. I'm going to move on because we have so many topics to talk about. Let's talk about heart failure. I hear this term so often where someone tries to walk up a flight of stairs and they're short of breath and they have swollen legs, and someone says, you have heart failure. Where have we come with it? How do you diagnose it?
Well, to begin with, everybody thinks that anyone short of breath has heart failure, and that's very, very far from the truth, because many things make you short of breath. Heart failure really means the heart is not able to pump enough blood to meet all the demands of the body. In other words, it has to pump blood, oxygen, nutrients to all of the tissues. If it doesn't, if the heart is very weak, People may get very fatigued, very tired, maybe confused sometimes, and the blood may also back up into the lungs. Then they may get short of breath. Now they found out in the last few years that if your heart pump is completely normal, you can still have heart failure if your heart is very stiff. So the question is, what gives you a stiff heart? It can be mainly from high blood pressure, diabetes, a variety of heart conditions, valvular disease. So there are really several types of heart failure, and while it's not good to have it, there certainly are treatments available for it.
Tell me a little bit about the genetics of heart disease. I think somebody mentioned a little earlier that if you had someone 45 years old, if your father at 45 had a heart problem, it's something to be concerned on. So genetics and prevention. I mean, we always want to talk about what we do, and it's so exciting, the anatomy, the new catheters that we have, the new interventions. But what could someone do who's concerned about preventing having heart problems?
Well, you know, yeah, genetics predispose us, and we cannot get rid of our family. So that's one. But there's a strong interplay between genetics, the environment where we live, and our activities. So mainly our activities that are exercising, eating healthy, and not, falling prey to our environment where everybody's eating, mac and cheese and double cheeseburgers. So we have to, at some point, say, you know what, I have this predisposition to develop early coronary disease, so I have to change my behavior, since we cannot change our genetics at this point until we get to, some very interesting things coming up, such as gene therapy and so on. So for now, we have to modify our behavior, what we call lifestyle changes. Exercise at least 150 minutes a week, eat healthy, and
eat healthy, Mediterranean diet, they call it DASH diets, different diets.
DASH, Mediterranean, any of these, healthy diets.
Low salt diet, of course.
Low salt, and stopping smoking. Smoking is one of the worst things that we can do to ourselves.
Tony, you've been on Staten Island for a while, and we'll talk about smoking a little bit.
Yeah.
What do you think about the population on Staten Island with regard to smoking, trying to keep fit?
I think there's a lot of them, but with the availability of some group therapy and some medications, they're getting to them free by calling 311, and some of them works. But in my experience, about 30 to 40% only stops. But now I think with the price of cigarettes going up, I think it's going to probably going down. Now, about genetics, you mentioned, it's important that that we have now treatment for patients that we call familial hypercholesterolemia. And they are now being treated with aggressive, massive doses of the statin, which decreases your cholesterol and your bad cholesterol. But if you don't get it down to your goal, there are now available treatment modalities for that. And that is why it's important to diagnose genetic predisposition to coronary artery disease, because we can do something about it.
So there are marathon runners who have high cholesterol levels because a lot of it is genetic.
Yes.
So some of these new monoclonal antibodies to reduce
That's
it
correct,
are
can reduce it. And it's amazing because they already have some studies to show that they can prevent mortality and decrease the incidence of stroke and heart attacks.
People could live longer.
Can live
that's
longer,
good.
and this is what is called the PCSK9 inhibitors.
Dr. Garman, what I want to do is we're sort of almost concluding. Tell me about the team approach. You run a team. You're the head guy.
Right.
So there's a lot of people who work with you, and I see it as running the neurology team, which is a lot smaller than the cardiology team. Tell me a little bit about the team of people that are with you and how you all work together. Do you meet every day? Do you meet on rounds?
Well, the
nurses and people like that.
most important person on the team is the patient to begin with, and the patient's family. We can't leave them out. So in addition to that, we have house officers, interns, residents, cardiology fellows that all see the patients. They examine them, speak to them, do testing on them, and bring that information back to the team. The team consists also of nurses, nursing care coordinators, a whole variety of people that are necessary to take care of every patient.
So tell me, so that's how the team works together. Let's go a little bit about what's new in cardiology. And maybe I'll actually ask you a different question, a little bit differently. You run a cardiology department at Richmond University Medical Center on Staten Island, and we're all part of that hospital, and also have been part of many other hospitals, including hospitals in Manhattan. If someone has cardiac disease, and it's someone that you care about, which we care about all of our patients very deeply, can Staten Island, can the outer boroughs, can the community provide the similar services that are available in Manhattan at some of the university centers? Or if someone goes to any of our offices and something is abnormal, do they have to immediately take the express bus in or drive into a hospital in the city?
Right. Almost all cardiology procedures can be done successfully, have been done successfully on Staten Island, but there are some really new, innovative, high-tech, unsafe procedures that would require more equipment and more expertise than we might have. But I would say 95% of all cardiac conditions can be very well taken care of on Staten Island.
So let me ask everyone. So Dr. DeVore, I mean, you do a lot of interventional work. You're the head of the interventional cardiology department. What's your opinion about where people should get different treatments?
Yeah, it depends on the severity or complexity of their disease. And as Richard mentioned, most of them we can take care of them here safely. But if we deem that it's a high risk, it'll be unsafe to do it in our hospitals, then we should transfer those patients to a facility where they have the expertise and who do this day in and day out. Sometimes I take some patients, very few, and do them in another hospital in the city. And it could be the same person, but the equipment, the staffing, the expertise of the support staff is very important in some cases.
So Tony, again, you being in practice for a lot of years, tell us a little bit about what you think about that.
So I think our hospital, for example, can manage all these patients that most of the time that we see as a bread and butter cardiology cases, okay? Dr. DeVore's lab can assure me that he can be there when I send a patient with a heart attack in the OR to the cath lab within 90 minutes, and certainly we can do that on a 24/7 basis. If I need a TEE or anything, I can ask Dr. Grodman to do it. And I have the report the same day, and you can't do better than that. The other thing is that we have the facility for, also from the electrophysiology point of view, certain atrial arrhythmias, like atrial flutter, we can do radio frequency ablation from them.
There are treatments for
There are treatments for them which we can do safely in the hospital. Okay, short of doing cardiac surgery, I think we can be able to provide the community these available procedures that we have. And we have done it, and you can see the amount of coronary bypass surgery has come down. Because if you have a patient with 1 or 2 vessel disease with the normal left ventricular function who is symptomatic, Dr. DeVore will put a stent on this.
I hear you. We're coming to the end. I'm going to ask Dr. Grodman to just ask one last question for a few seconds. What do you do if you have chest pain?
That's a very good question.
You go to the hospital.
You worry about it. That's the first thing you do. The problem in our country, not just our state, is...
We're almost finished, so they're going to say...
People ignore their chest pain, and they shouldn't.
They have to go to the hospital.
Correct.
If you're worried about it, don't think it was your dinner. I want to thank everyone.
Yes.
We could be speaking for a lot longer. I want to thank everyone for coming, and wonderful to speak with you all. Thank you all again.
You're welcome.
Thank you.